안녕하십니까.
Greetings,
이좋은치과의
I am
손영입니다.
Dr. Sonyoung of E-Good Dental Clinic. Today I'm going to talk about immediate implant placement. I'm going to talk about theories of immediate implant placement and precautions that we need to take and prognosis. Immediate implant placement. After extraction, in the extraction socket, you place the implant body. This is being done regularly. Let me show you the general treatment process of immediate implant placement. The patient complained of pain and discomfort in number 35. On panoramic image, there is a slight translucency here. If you look at the clinical image, gun boil can be observed. On standard radiographic image around the post, there's extensive bone loss. I think this is root to fracture. Extraction was done. Implant was placed. Gap was managed. Suture was done. This is called immediate implant placement. This is after implant placement. On panoramic image, implant has been placed. In most cases, if there is sufficient primary stability, healing abutment is connected and one-stage surgery is completed. If you look at post-op CT image, implant body has been placed in the bony housing. This is after healing. In general, healing process takes place if there's good primary stability, or if there is a small gap, it takes about 2 months. If there is a big gap or bad primary stability, I wait about 16 weeks before I deliver the final prosthesis. Prosthesis has been delivered. These processes are the same as the general implant treatment process. This was how it was completed. This was the process of immediate implant placement. The reason behind immediate implant placement. When you do extraction, as we all know, there's loss of soft and hard tissue. In 1967, Piotrowski reported this study. Cast was used for measurement. What we need to note is that compared with the lingual side, there's a lot of bone loss on the buccal side, about 2 times than that of lingual side. Extraction was done quite some time ago in this alveolar ridge, and you can see that on the buccal side, hard and soft tissue is quite significant. Let's look at Schwab's study in 2003. If you do extraction, the bone height, after 12 months, there's vertical bone loss of 1.2 millimeter, and in terms of width, after 3 months, a 3.8 millimeter loss occurs, approximately 30%. After 12 months, it's 6.2 millimeters loss, so 50% loss of overall width. According to Schwab, most of tissue loss occurs within a couple of months since extraction. The conclusion is that 1.2 millimeter of vertical loss occurs and 50% of horizontal dimension loss occurs. The ratio between buccal and lingual side, loss occurs 2 times more on the buccal side. Why does such tissue loss occur after extraction? Why does soft tissue loss occur around the alveolar bone? There are many theories. What is really credible is that bundle bone theory. I'm going to give you an example of bundle bone. This is a bone with PDL. In other words, it receives blood supply from the PDL and maintains vitality. This is called bundle bone. You can see bundle bone in septal bone of a molar. 2 to 3 millimeter of coronal part of the upper anterior is bundle bone. Septal bone, if you remove it, then the bone is gone because it does not receive a blood supply. In upper anterior, the coronal side, 2 to 3 millimeters of it, this is categorized as bundle bone. At the time of extraction, you check the existence and then proceed with extraction. With time, they disappear. So before extraction, it exists, but after extraction, we need to think of it as disappearing. And because of these changes, soft tissue changes occur, and more changes occur on the buccal side compared with the lingual side. This is bundle bone. Can we prevent alveolar bone resorption by doing immediate implant placement? We do immediate implant placement under the presumption that we can prevent alveolar bone resorption. Immediate implant placement. There's a study on whether immediate implant placement prevents alveolar bone and soft tissue loss. This is reported in 2004. This compares immediate implant placement and delayed implant placement and looked at dimensional changes in these two types of treatments. If you look at this table, it's very accurate. At the time of implant placement, the ridge width is approximately 10 millimeter, and at second surgery, it becomes approximately 8.1 millimeters, so 1.9 millimeter decrease. In the case of delayed implant placement, which is implant placement after 6 to 8 weeks after extraction, at the time of implant placement, the ridge width is 8.86 millimeter, and at second surgery, it becomes 5.8 millimeters, so decrease of 3.06 millimeters. Therefore, if you do immediate implant placement, the dimensional changes are smaller than when you do delayed implant placement. In terms of preventing dimensional loss, I believe it is more favorable to do immediate implant placement. Then how stable is immediate implant placement and what kind of prognosis does it have? Let's take a look at a study. As shown, in extraction socket, if you place an implant, what kind of clinical results can result? This is a study on that. This is an ITI treatment guide, volume 3, which looks at implant placement with different timing. Type 1 is immediate placement. Type 2 is early placement with soft tissue healing, typically 4 to 5 weeks of healing. Type 3 is early placement with partial bone healing, typically 12 to 16 weeks of healing after extraction. This is type 3. Type 4 is late placement of more than 6 months of healing. This study compares types 1, 2, 3, and 4. There are different results. Let me share with you the conclusion. In this study, it talks about 3 aspects: regenerative aspect, survival rate, and the aesthetics. If you look at conclusion, immediate placement does not prevent vertical and horizontal resorption. I agree. It does not prevent 100%, but you can reduce the amount of resorption. When bone augmentation is accompanied, horizontal resorption can be reduced, but vertical resorption cannot be reduced. Bone augmentation procedures are more successful in combination with immediate and early placement. In the case of Dees's defect, rather than immediate implant placement, regenerative outcomes are better in early placement. This is about machined surface. I'm sure you all know this and agree. The success rate is lower in machined surface. Early placement is associated with a lower frequency of mucosal recession compared to immediate placement. Risk indicator for recession with immediate placement include a thin tissue biotype because if it's thin, there's more risk. Another is facial malposition of the implant. In other words, if the implant is placed too buccally. And third is thin or damaged facial bone wall. These three are a risk indicator. When you do immediate placement with bone augmentation, horizontal resorption can be reduced. And based on this information, we do immediate implant placement after extraction. Let's go in deeper. With such knowledge in mind, we perform immediate implant placement after extraction. What kind of factors affect the clinical result when immediate implant placement is done? The factors that come into play is how extraction is done, primary stability of implant body, and horizontal and vertical position of implant body, size of horizontal gap, when graft is done or not, thickness of buccal plate, and gingival biotype. These affect the clinical result when we do immediate implant placement. In this lecture, I'm going to talk about first a couple of factors that come into the play. When we do immediate implant placement, we need to do a traumatic extraction. This is a must-have. Traumatic extraction can lead to microfracture, and because of this, there can be disruption in blood supply, leading to swifter alveolar bone resorption. Therefore, a traumatic extraction is essential. If you look at different studies and literature, there is no meaningful difference between traumatic and atraumatic extraction. Some say this. However, if you can avoid traumatic extraction, that'll lead to better result. What do we need to do to provide atraumatic extraction? First, my recommendation is to use periotome. You can apply periotome in the PDL space. You can cut PDL first. Using melting, you can cut PDL. If you use periotome, you can minimize damage to the alveolar bone and alveolar process and do extraction. If it is too thin, as shown, you can use blade number 15 to cut the PDL. Second, you should not extract all at once, and you can do separation and sectioning to do extraction. You need to separate mesiodistally. You should not do it buccopalatally or buccolingually. Because we need to insert elevator in the labial plate, this is not recommended. You need to separate it mesiodistally, and you should make sure that the elevator does not contact the facial wall. Second is primary stability of implanted body. The biggest challenge we have in doing immediate implant placement is to get primary stability. When I come up with treatment plan, when I plan for immediate implant placement, I always ask myself whether I will be able to get primary stability or not. Talks of primary stability after immediate implant placement was first introduced in Lazara's literature in 1989. The preconditions and biological precautions were discussed in terms of immediate implant placement. There needs to be approximately 3 to 5 millimeter of basal bone in order to get primary stability. Based on my experience, you need to have at least 3 millimeter of basal bone to get primary stability. And this is a study, that's the gist. It also talks about conditions for bone formation in extraction socket in contact with the implant body. Some of it is a little bit outdated. What we need to focus is that implanted body needs to be placed more towards the apex in consideration of soft tissue regeneration. Second, in order to get the primary stability in immediate implant placement, you need to consider implant body design. As you can see, there's a straight body, semi-tapered body, or fully tapered body. As you can see, it is most unfavorable to get primary stability in immediate implant placement using straight body implant. Preferably, you should use tapered body, so T3 in the case of ostium, to get better primary stability. It'll be much easier to do that. In the case of apex design, rather than choosing implant without a round head or self-tapping thread, you need to choose implant with self-tapping thread design. That is much better in getting primary stability. The pitch, depths, and thread form of implant can also affect the implant placement, but if it has a too big thread or pitch, it can be unfavorable. You need to take note of that. Let's take a look at the patient. The primary stability is essential. In this case, in number 36, root fracture occurred. This is oral cavity. There's nothing really that stands out. A traumatic extraction was done. Fractured root tip was removed. Second, you need to remove granulation tissue thoroughly. If there is a soft tissue within the extraction socket, if it's really small amount, it does not really affect the prognosis, but preferably it should be fully removed. In the case of lower 6, first drill is essential in impacting primary stability and prognosis of an implant. The drilling needs to be done on the septum accurately. However, in the case of lower molar, accurate drilling is not easy because drills can slip and shift. There are difficulties associated with that. If you slightly tilt lingually and drill on the septal bone, you can get very good implanted position. You need to drill on the accurate position. In order to do that, there are many tips available. There are drills available for septum drilling, and they're in use a lot. I personally don't use them. I just use Lindemann drill within the surgical kit. When you do initial drilling, it is not ideal to use low RPM drilling. If possible, you should drill high speed 1200 to 1500. This is to prevent displacement of drill. I'm sure those of you who have had experience doing immediate implant placement will agree, but initial drilling determines almost everything. It is very important to do initial drilling in the appropriate position accurately. It really determines everything. Third, I've talked about how high-speed drilling is recommended for initial drilling, but at times low speed can be favorable. In final drilling step, it is better to do low speed. To get better primary stability, you can do undersized drilling. That is recommended in a lot of cases. When the RPM increases, the cutting power of the drill goes up. However, the tactile sense we get with our hands drops, and if the drill RPM gets lower, the cutting power drops. However, the tactile sense goes up. If undersized drilling is necessary, or if it is deemed that undersized drilling is okay, as shown, in order to drill accurately, I drill 50 to 100 RPM as a final drill. I believe this is quite useful. You should not start off with low speed drill. If you use high speed and if you are unsure how deep you are in the final drilling sequence, you can use low speed drilling. That is recommended. Using this method on the septum, implant has been placed accurately. This is how implant has been placed. Healing abutment is connected. In immediate implant placement cases, it is very difficult to get primary closure, and realistically speaking, it's impossible. In one-stage surgery, you do transmucosal bone graft and connect the healing abutment. And the bone graft is done and suture is done. Compared with traditional GBR, it's more simple, and this is a big benefit in terms of immediate implant placement. By doing this, you can get regenerative help from the surrounding periodontal ligamentous cell. A more positive regenerative outcome can be gained. Implant has been placed. As for prosthesis, I wait approximately 16 weeks. I wait longer before I do loading. So I believe from week 12, loading may be possible. Prosthesis has been delivered, and this is follow-up. On CT, as you can see, buccal bone has been regenerated. It's quite favorable. I'm continuing to follow up with this patient, and the patient is not experiencing any complications. As shown, it is very important to drill in accurate position and accurate depths. And to do this, initial drilling is very important. What should you do if you cannot get primary stability? In this case, you can submerge it. In this patient, in number 36, furcation and bone loss occurred. Immediate implant placement was decided on the X-ray image. On the inferior area, it doesn't look as if there's a lot of basal bone, and I knew that there was going to be difficulty in getting primary stability. Drilling is complete. I did drilling on septal bone. The drill hole, because there's bone loss below, you can only get primary stability from the basal bone. You cannot get any stability from the lateral wall. It has been placed, but primary stability was very bad. In this case, you do not close off surgery with healing abutment, but you do bone graft and connect the cover screw. You submerge the implant. This is a technique you can use at times. Bone graft is done. In this case, non-resorbable PTFE membrane was used. It was covered and suture was done. When you do suture, you do not need to strain yourself to get the full primary closure. This is post-op image. CT. You can get better result if you do overgraft slightly. On average, after 4 weeks, membrane becomes contaminated, and at 4th week, if you remove it using forceps, you can see pseudoperiosteum and not bone graft material. Below membrane, there's always a connective tissue layer of about 1 millimeter, and below that, bone regeneration occurs. Yes, there are collagen membranes that do not follow this process, but in most cases, there's approximately 1 millimeter of connective tissue layer. Even if you remove membrane, you don't see bone graft material, but connective tissue layer. The outer surface and inner surface. If you look at the inner surface, there's no contamination. This is after 4 months of implant placement. Connective tissue layer is becoming keratinized. First, OP is done. The patient came to the dental clinic significant time later, and prosthesis was delivered 7 months after the surgery. 7 months after surgery, prosthesis was delivered. If primary stability is bad, you can submerge it. Of course, you can forego implant placement and just do socket preservation and wait for healing to occur before placing the implant. This is summary. Today I've talked about immediate implant placement. As mentioned, you need to equip yourself with sufficient amount of knowledge before you go ahead and perform immediate implant placement. These days, immediate implant placement is a treatment option we can provide daily. One of the important factors in doing immediate implant placement, you need to do atraumatic extraction. When you do immediate implant placement, in order to get good result, starting from extraction, you need to minimize damage to the surrounding tissue. You need to use periotome to cut the PDL. You need to utilize such techniques. In order to get primary stability, you need to use a tapered implant with self-tapping design. You need to adjust the speed as well. If you fail in getting primary stability, you do not need to remove the implant, but submerge the implant body and wait for healing to occur and revisit it later. Today, I've talked about immediate implant placement. In order to do immediate implant placement successfully, it's very important to get primary stability. You need to thoroughly plan immediate implant placement. After extraction, you need to carefully follow up on the changes in extraction socket to do successful immediate implant placement. This is the end of my lecture. Thank you for watching.